Good evening. Thank you very much for giving me this opportunity to be with you today. I hope to be fast and on time. I first will raise the question and then we will solve the problem. So the first case is a 74-year-old gentleman arriving to ER because of fever, chills, abdominal discomfort, and difficulty in urination for 4 days. He was visited already in another clinic because of 2 nights stenosis and suprapubic discomfort. He is diabetic, hypertensive, hyperlipidemic, and had cholecystectomy 2 years ago. He has fever, chills, nausea, vomiting, suprapubic tenderness, icter, chest X-ray is normal. What will be your decision? What will be your selection? Urine analysis done, came white BC, many bacteria, many. So there is 2 things you should decide. First, about the treatment. Second, about admission or discharge. Do you admit this patient or discharge? Admit. And what will be your selection? Fortunately, the 2 days ago visit ended up to a urine culture, which came positive for E. coli, and it's sensitive to carbapenems, aminoglycosides, and piperacillin tazobactam. In oral medication, it's sensitive to cotrimoxazole and nitrofurantoin. What will you select? Which one? Our colleagues selected imipenem, but then we had to de-escalate. And you see that there is other choices, and it's not necessary to go for the broad-spectrum carbapenem from the beginning. The case number 2 is 60-year-old lady visited as outpatient with dysuria, frequency, urgency, suprapubic pain, mild right flank discomfort, no fever, vitals stable, history of UTI last year. She is menopause and has type 2 diabetes mellitus for 3 years on metformin. Again, what will be your decision? What will be your selection? Before having the cultures, as outpatient clinic, will you admit or discharge? Discharge. What will you select? Oral treatment what? Augmentin based on the culture. But we should look at our daily practice. What we use daily practice. In the first day of the clinic, are we going to give augmentin? Yes. Now we will discuss it in the UAE guideline also. So urinary tract infections are very common, most common in women, most common in hospital settings. And after first episode, there is increased risk of having the second episode for women. And women are having more urinary tract infections than men. Most common bacteria, as you know, either in uncomplicated UTI or complicated UTI, the first is E. coli and other gram-negatives. Then we will come to gram-positive, Staph saprophyticus, or Staph methicillin-sensitive, or MRSA, and enterobacteria, Enterococcus. When you should think about broad-spectrum antibiotic, when you think about broad-spectrum antibiotic, when you think about the drug resistance, what is the chance, what is the predisposing factor for drug resistance? Any of these things happened during past 3 months for your patient, think about the drug resistance. If patient had a multi-drug resistant urinary tract infection during past 3 months, urinary tract infection with an organism resistant to quinolone in past 3 months, have been admitted or had been under care in a health care facility, either hospital or nursing home. And if patient had used a quinolone or cotrimoxazole recently or a broad-spectrum cephalosporin, we consider cephalosporins as broad-spectrum when they are third generation and higher, or have traveled to the part of the world with the high resistance prevalence. And symptoms are, am I spent 10 minutes? Oh, we have 10 minutes, okay. And symptoms in lower tract, dysuria, frequency, urgency, hematuria, upper tracts, same symptoms with adding fever, chills, nausea, vomiting, and CV angle tenderness. Is urinary tract infection being complicated? Yes, it can be. It can end up to bacteremia, sepsis, multiple organ system dysfunction, shock, and acute renal failure, mostly in elderly or diabetic patients. And it can spread beyond the kidney contour to make renal corticomedullary abscess, perinephric abscess, or emphysema pyelonephritis, mostly in people with obstruction or diabetes. When we admit, when we discharge, we admit patient who cannot take oral, or we admit patient who is not well, septic patient, on septic shock, very ill, dehydrated, or there is obstruction. No doubt should be admitted. In between, for those who cannot take oral, but otherwise they are fine, we can use OPAT, outpatient antibiotic therapy, with daily instructed IV or IM antibiotics. And if the patient is stable, can take oral, is available to follow up, we will not lose the patient, and good to discharge, we will discharge on oral antibiotics, but we should follow up closely. What is happening these days? ESBLs, beta-lactamase introducing E. coli and gram-negatives are increasing. And a kind of E. coli, type 131, ST131, is spreading around the world, which is responsible for resistance to quinolone and other antibiotics. Carbapenem resistance is also increasing. This is the world map by World Health Organization. You can see those areas with strong antimicrobial stewardship programs having less resistance. They are green or they are yellow. And those with less ASP programs or newly implemented or not successful, where the antibiotics are using widely, are orange and red. Middle East is in dangerous area. And some part of Europe, also some part of Africa. Australia and north of Europe and Canada, they are still facing less drug resistance. There are a lot of studies from the UAE, like article from Mansour Al-Zaruni, who had looked at the drug resistance in organisms and found that in E. coli, we had 39% ESBL, and in Klebsiella, 42%, and Klebsiella oxytocca, 100% of cases he found were resistant, were ESBL positive. The study has done on 2008. After that, the growth of ESBLs has been more and more. So it's not a horror movie. ESBLs are true. They are really a true story, and we should think about them. For treatment, there are a lot of guidelines. There are a lot of guidelines that we can find, but how many of us are aware of UAE national guideline on UTI? Have you ever used it? By the help of antimicrobial stewardship program, UAE antimicrobial stewardship program, the national guideline on empiric antibiotical treatment for urinary tract infection was designed. By looking at the United Arab Emirates cumulative antibiograms, which our labs are reporting their data to Abu Dhabi, and they collect the data and they release such a table about drug resistance, we can look, for example, we will look at E. coli. Our E. coli is 74% sensitive to amoxicillin, 94% to tazocine, carbapenem sensitive, aminoglycosid sensitive. When we look at ciprofloxacin, 62%, and nitrofurantoin, 94%. In carbapenems, look at our E. coli and even Klebsiellas. See, there is no difference between ertapenem and meropenem. So why we are using meropenem? These days, ID physicians mostly stop in meropenems, and they don't start usually. We should not use meropenem if it is not necessarily indicated. And in Enterococcus fecalis, most of our organisms are 99% sensitive to ampicillin. Means when they are sensitive then to amoxicillin and amoxicillin. And also they are 99% sensitive to vancomycin and teicoplanin. The UAE guideline divides based on your diagnosis, how to treat. For uncomplicated cystitis, we don't do single dose anymore except for fosfomycin. Fosfomycin is a very good medicine, single dose. In uncomplicated cystitis, we can repeat if needed. Otherwise, if we go for nitrofurantoin or amoxiclav, the treatment will be 5 days. For complicated cystitis, again, nitrofurantoin first choice, fosfomycin second, or fosfomycin, but look, here it is 3 doses when complicated cystitis, and augmentin for 5 to 7 days. For uncomplicated pyelonephritis, first choice is amoxiclav, 1.2 gram IV every 8 hours for 7 to 10 days, plus either gentamicin or amikacin, or ceftriaxone plus either gentamicin or amikacin. Alternatively, if patient is allergic to beta-lactams, we can go for alone gentamicin or amikacin for 7 to 10 days, but we should be careful about kidney function and adverse drug reactions. Complicated pyelonephritis, here piptazo comes. It's the first time in the guideline we reach to piptazo. It's only for complicated pyelonephritis, not for all pyelonephritis cases, and goes to 7 to 10 days. If there is history of ESBL or previous colonization via ESBL, or you think about the drug resistance, then you can go for carbapenems like ertapenem. Whenever you're thinking about meropenem, ask this question: where is Pseudomonas? If there is no Pseudomonas, no meropenem, you can go easily with ertapenem. And alternatively, you can use cefepime plus gentamicin or amikacin for 5 to 7 days, for 7 to 10 days. Pregnant women, asymptomatic bacteriuria, only indication to treatment pregnant women. So again, nitrofurantoin or fosfomycin. 1 dose fosfomycin. Fosfomycin has long half-life, stays very well in the system, and we need to treat only if necessary. And amoxiclav for 5 days is the alternative treatment. Complicated cystitis, nitrofurantoin, fosfomycin for 3 doses, augmentin, amoxicillin, clavranate for 5 to 7 days, and pyelonephritis, piptazo, and if there is history of ESBL, previous colonization via ESBL, ertapenem 1 gram daily for 7 to 10 days. Alternative, cefepime is 7 to 10 days. But we should be very careful about the cultures and antibiograms. If we start aminoglycosides, we should continue till we have the culture results. In the guideline, there is 3 doses of once a day aminoglycosides. It's designed for usual culture timing, and we can stop or continue based on the culture results. Cotrimoxazole is not advised to be the first start antibiotic for urinary tract infection based on the cumulative antibiograms of UAE. And for penicillin allergic patients, we can go for vancomycin plus amikacin or ertapenem. Why we use vancomycin here? We use vancomycin because gentamicin can use gram-negatives, and it's very effective in most of our drug-resistant cases. We use vancomycin here to cover enterococ. So the reason of adding vancomycin is mostly enterococ, and if there is a staph or a streptococcal infection that we need to cover. And there is a hint about quinolones. Quinolones are now in black box warning of FDA because of their adverse effects. If you have to use quinolone, better not to use it as your first selection. They have a lot of adverse effects. They are making collateral damage, means that they increase the drug resistance in the community. And moxifloxacin will not cover urinary tract infections. Any antibiotic that you don't need to adjust the dose means there is no effect, no secretion in the urine. moxifloxacin, tigecycline, they don't have secretion inside the urine. So we are not going to use them for urinary tract infection. Thank you.